So while Alex shares his screen, I'll go ahead and just do a brief intro, Alex. Go ahead, Alex, you can share your screen. So I'll have the privilege to present Dr. Alex Zhornitskiy. He received his medical degree at Drexel University, College of Medicine, followed by internal medicine residency at UCLA, all of you, as well as the medical center. He's currently a second-year GI fellow in UC Davis, and his mentor, Dr. Mao, is on the call. He's an active member of AGA as part of the Young Delegates program. His interest really includes addressing disparities in underrepresented populations through healthcare advocacy, education, research, and he's a rising third year and plans to pursue general GI. So go ahead, Dr. Zhornitskiy.
Awesome. Thank you so much for the introduction. I appreciate you guys being here. Gonna, oops, using the wrong mouse. Okay, gonna get started. So my talk today, and I'll kind of get into why and how this came about in a sec, but is looking at the epidemiology and like that clinical outcomes of hospitalized Hispanic patients with IBD. So this is like a national cohort study that was done. And I'm working with Dr. Mao, who's been amazing and a great support. Okay, so why am I even interested in this, and why should we be interested in this? You know, I don't know what your guys' education was, but I feel like I didn't finish medical school all that long, and I learned that IBD is a disease that's mostly amongst Western European Ashkenazi Jews as well. It's not really a disease that we're seeing in other populations, but that's not exactly the case, I think, and we just don't know much about it. So specifically, like IBD in Hispanics, the studies that we have been done are predominantly in non-Hispanic populations. So Olmsted County studies that have looked at incidence and prevalence of IBD in Hispanics had very minimal. There's been multiple renditions of these studies, but they've been very minimal overall in terms of the amount of Hispanic patients that have included. Overall, it's typically like 80 to 90% of non-Hispanic white patients. And often some of them have just even put every other ethnicity, every other minority into kind of a group of other, and then extrapolate data from that. There was a big study using a national health interview survey that was also, again, national. It sounds like you're really involving a lot of different people and large quantities of people. And in fact, when you look at the data from these studies where they were showing that non-Hispanic white patients had 3 times the rates of IBD than Hispanics, they ultimately only surveyed 12 Hispanic patients, and the way that they surveyed them, and they extrapolated basically that data in terms of figuring out rates of IBD in Hispanic populations. There have been some better studies that include larger groups of Hispanic patients, but several of them use like exclusively patients from Puerto Rico. And that's pertinent because that is North America, but that kind of the lifestyles and the things going on in Puerto Rico are different than in America itself. And I say that because there's been this developing understanding of IBD, and I'll touch base on this in a little bit, that there's a very important predictor is when did a country undergo industrialization? As there's all these, there certainly are genetic factors, but there are also environmental factors. And so using patients that are not in the United States to try to extrapolate what things about Hispanic patients in the United States, and using only one group when the term even Hispanic, probably we should be using Latinx, but all these studies have been using the term Hispanic, is inaccurate. And so in more recent research looking in other places, Africa, Asia, South America, over the past several decades, showing there's a rising incidence of IBD in these countries. And it's interesting that there are some much smaller studies, but looking at immigrants who immigrants to westernized countries from non-westernized countries and seeing what the rates of IBD are. And usually in second generation immigrants, you're seeing pretty similar rates of IBD as you would be in the native populations. Again, these are overall fairly small studies, but suggestive of pretty significant environmental component to what is going on, aside from this kind of our basis of, or kind of our tenet of understanding has been based on that this is predominantly all genetic. So then this kind of led into the study to try to take a look at, well, what is our understanding of IBD in Hispanic patients in the United States? I'm not going to delve into all the research that we have so far, but the research that is a little bit more accurate, that actually involves larger quantities, larger numbers, I should say, of Hispanic patients, is really focused in certain institutions. There's some great studies coming from Northern California, Kaiser, previously, some great studies coming out of Miami, but they are all more local studies based on a single institution or a few different institutions in one area. So I looked at the national inpatient sample. You're like, what is that? So it's, I need to move this little thing away. That's the largest publicly available inpatient care database in the United States. And it looks at 7 million hospital stays per year. And I looked specifically at the years 2016 through 2020. Reason being, that's when ICD-10 was introduced in 2015. So to make things easier, it went from 2016 to 2020. And so I'm just going to go through some of my tables and make some commentary. And feel free if I'm going over time to also cut me off, and we can just kind of talk about the stuff that I got through. But let me, so I can see my own screen and get adjust a few things. Okay, so this is basically what we're seeing is in this table is, in terms of total hospitalizations, there's significantly more hospitalizations amongst white patients than, and this is non-Hispanic white patients versus Hispanic patients. But I would point out that the proportions, I don't have them calculated here, but the proportions are pretty similar to the makeup, at least according to the last US Census, of Hispanic patients to white patients, non-Hispanic white patients. So then when you're actually looking at the rates per hospitalization, you are still seeing a significant higher rate of hospitalizations among white patients across the board. And you might be asking why IBD, Crohn's, and UC, like, are these all, is Crohn's and UC, is this cumulative and it amounts to the IBD? Not really. And again, this deals with the challenges of using ICD codes. Is someone can be listed as inflammatory bowel disease, but might not share a listing as denotation as ulcerative colitis and Crohn's. So one of the things we can talk about under limitations. In terms of gender, it seems like across the board, higher rates of females with inflammatory bowel disease in white patients. White patients have our median ages trends older, and then I broke it down into categories by years, and you're seeing that both in UC and Crohn's. In terms of insurance types, which is, I think, very pertinent, white patients are significantly higher likelihood of having Medicare or private insurance. Hispanic patients have much higher rates of Medicaid and being uninsured, and you're seeing that across the board. In terms of some of the looking at some of the management, and again, some of the limitations of this database is that can't really evaluate biologics or some of the more kind of in-depth things that we look into for IBD, but we can look at steroid use, so higher rates of steroid use amongst white patients. You can look at looking at small bowel surgery, specifically for Crohn's disease, higher rates of small bowel surgery amongst white patients compared to Hispanics. In terms of partial colectomy and total colectomy, you're seeing I guess more, well, maybe total colectomy being more pertinent for UC, but higher rates for white patients relative to Hispanic patients, higher rates of rectal surgery for Crohn's patients that are white relative to Hispanic patients. And probably should have mentioned this, but taking a step back, these patients who we're looking at, they were hospitalized with the primary diagnosis being one of these ICD codes, either Crohn's, UC, or kind of this catch-all of IBD. So this is specifically individuals who are coming in for presumably some sort of either flare or complication of IBD, like it's their primary diagnosis code for these hospitalizations. ICU admissions, there's no particular, no significant difference across the board. Not seeing a significant difference in length of stay. Interestingly, are seeing a significant difference in mortality amongst white patients relative to Hispanic patients. Wondering, is there kind of a more severe, more likelihood of more severe flares? And is this predominantly driven by ulcerative colitis, the UC patients specifically? And the UTR that's noted here is basically if there's under 10 hospitalizations for any category, it's not reportable. We're not allowed to report it for the database's rules. And the other interesting aspect is total charges, where despite all these, what we've been talking about, that white patients have higher rates of surgery, higher rates of steroid use, total charges are significantly higher in Hispanic patients across the board, whether it's the catch-all IBD, Crohn's, or UC. And charges, it's not like a great, thing to look at, because it doesn't actually translate into cost necessarily, but it kind of this cumulative thing. And then looking at, we kind of further went on to break down year by year. So that was all cumulative from 2016 to 2020. And I just want to highlight kind of the major points for when you're looking at year by year. What you're seeing here is these p-values. That first column is the p-value for comparing the rate of change amongst white patients for that first category being the rates of hospitalizations. And then the second column is you're comparing the rate of change of Hispanic patients over the course of those 5 years to the rate of change of white patients. And so you're not seeing a significant difference in the rates of hospitalizations overall in IBD. Some question marks are still, this is a work in progress. But you are seeing rates of a significant difference in the hospital charges. Now, year-to-year charges are different. So a surgery may cost a certain amount one year and a certain amount another year. But if you look at that second p-value column, you are seeing that the rate of change for Hispanic patients is higher than the rate of change for white patients year to year. And just to highlight again, you're seeing that for the hospital charges for Crohn's patients being higher in Hispanic patients relative to white year to year. And then for ulcerative colitis, we're still trying to kind of figure out the p-values, but at least observing it, and this is not a completely objective way of measuring it, but you're seeing pretty significant, what looks like a significant increase in year-to-year change of hospitalizations, the rate of hospitalization for Hispanic UC patients. So we're trying to figure out that data currently. But again, you're seeing the hospital charges. But in UC, you're not seeing the hospital charges, rather having a significant difference. So a lot of different numbers, a lot of different tables. Just to kind of sum it all up, there's definitely limitations to this using a database like this, because the biggest limitation is this is not specifically unique patient encounters. This is like these numbers not looking at one unique a unique patient. It's looking at hospitalization. So one person can be counted 5 times, 10 times, 20 times. Argument against that is the proportions between Hispanic and white patients, again, are pretty similar to the census, but we don't know if that's exactly accurate or not. I think there's definitely some other limitations, but I'd say that's the predominant one. But the benefit of this is, looking at the research that we currently have, we don't really have a truly national understanding of much of these basic epidemiological factors and like hospitalization related factors between for Hispanic patients with IBD. And so it is imperfect to some degree, but there isn't much data. There really isn't any currently for us to get an understanding on a national scale what is going on and how it compares to kind of the traditional non-Hispanic white population. So that's my talk. Thank you guys for listening.
Thanks, Alex. Thanks for this amazing talk, and then also just kind of discussing different areas and analyzing your data that way, so you see different trends. I guess one quick question was, for NAS data database, I know they have some socioeconomic status, mainly zip code data. Did you look at for any other different sort of, we talk about environmental factors a lot, but like other social determinant factors?
Yeah, so there's also, which I didn't show, but there's it's not really, maybe this partially answers your questions, but like we have data also in terms of income, and there's a significant difference. Hispanic patients are more likely to fall in the lowest quartile of for income relative to non-Hispanic white patients, but there's not much aside from that in terms of like other determinants of health that we're able to glean from this database.
I feel like there's been a lot. I mean, there's the prior literature that you kind of sort of discussed in your earlier slides, where Hispanics sometimes are linked to different sort of complications or rate of dysplasias or different surgery, and a lot of it before it was kind of explained the delay of care. But then in your data, it seems like they're younger at the time of diagnosis, so which kind of helps argue against that fact. So maybe teasing out sort of, if, because they have zip codes, you always look at rural versus urban. I'm sure there's a difference between that. And there's a recent paper, I think just released right now with Dr. Sandra, or that is about looking at rural factors in IBD care. And I wonder if when you break the Hispanic, because Hispanic is it's kind of like Asians, right? Such a broad term.
Yeah.
And if you're able, and I know you're probably limited by the National Patient Sampling Database, but breaking distinguishing different subtypes of Hispanics can always be important as well. I know it may not be possible in this database, but then if that's not possible, then maybe looking at social determinant factors based on zip code, that you can always derive the zip code, look at rural versus urban, and then also the correlated income, and maybe there's a difference in terms of that Hispanic population that you're reporting as a whole.
Yeah, and that's a great point. And one of the other kind of along those same lines, one of the things trying to figure out is, again, and I hate the term, and I feel like forced to use it because it's, when you're trying to compare it to other research that has been done, and looking at like that, this is how it's is one reason I'm using. Another reason is like this is often how databases are like using this terminology. But yeah, the zip codes, the other aspect is like, breaking it down to the various regions of the country. Like they're obviously, each region has higher rates of populations of individuals from Central America versus South America from certain countries. So yeah, and rural versus urban, that's a great idea. I didn't think about that one actually. So thank you.
I mean, I'm happy to see that. I mean, usually people say Hispanic does worse, but it seems like in your database and your report, it seems like they do okay, if not a little better than their non-Hispanic counterparts.
Yeah, which I thought was very interesting.
Can I add something more? Specifically in Fresno, we have a fantastic children's hospital, and the children's hospital is taking care of all the kids with IBD. The problem is when they left alone and discharged from the children's hospital, I'm talking about the age 18 and above, they have difficulty to find a GI who will accept them, because nobody wants to see the IBD patients. And this is maybe contribute to this factor that Alex mentioned, that younger generation get admitted to this hospital because the delay of the care. You're right.
Yeah, thank you for that, Michael.
If there's no other questions, I'll just pause. If there's no other questions, I just want to thank you, Dr. Alex Zhornitskiy, as well as Dr. Eric Malley for mentoring and sort of sharing your amazing work with us. And kudos to embarking this big database. And this is not that easy to analyze, but I appreciate it.
Thank you guys for your time. Appreciate it.
Yeah. Dr. Malley, any comments?
Yeah, no, I think that we were thinking about looking at the I think this is work that needs to be done that sort of helps us learn more about how IBD behaves in different populations. And so I think Alex has done a great job in sort of spearheading this and looking into this.
Awesome. So we'll move to Leung, and he's a colleague at Kaiser San Francisco, and he just post calls. So I appreciate you for making it here. You've part of for the past 26 hours. So Dr. Leung received his medical degree at University of Vermont College of Medicine, followed by internal medicine residency at Kaiser San Francisco, where he continued actually first GI fellowship, and it's currently his first year. So doing research during your first year is no small feat. So we really appreciate that. And he is looking to possibly pursue a career in advanced endoscopy. All right, Lawrence, the floor is yours.
Cool. Thank you, Leung, for the kind words, and all of you for allowing me to present our research, and also Danny for coordinating all of this every single month or every single week, so to speak. Let me try to share my screen. But can everyone hear me okay?
Yes.
Okay, cool. And then I apologize in advance if you hear a dog barking in the background. I have like a dog that kind of runs around and gets a little reactive sometimes. So if you hear a lot of barking, I apologize for that. But in any case, this is a project I actually kind of worked throughout residency, and then it's essentially looking at post-colonoscopy colorectal cancer etiologies in a large integrated U.S. healthcare setting. So for all of us, we're all in GI, we're all in gastroenterology. We all love doing colonoscopies. They're fun, but also two, they're very beneficial to all the patients. They're very preventative for colorectal cancer. But what happens when someone gets a colonoscopy and yet they still have colon cancer down the road, whether it's like 1 year down the road or 4 years down the road? Why wasn't the colonoscopy effective? So this is more so looking into the etiologies that potentially can lead to someone having these so-called PCCRCs or post-colonoscopy colorectal cancers. Let's see. And did the slide advance for everyone? My screen's a little glitchy. Sorry about that.
Yeah, you see your slides.
Okay, cool. And for full disclosures, this was recently published, so this is a project that we already wrapped up on. And my co-authors include Jeff Lee, Sophie Merchant, Chris Jensen, Asim Alam, and Doug Corley. And we actually had funding by the National Cancer Institute by their PROSPER Consortium, which is a consortium looking into different ways and factors to optimize cancer screening. So as a background, how can we best define post-colonoscopy colorectal cancer in a consistent way, or PCCRCs? So as mentioned, colonoscopies are a valuable tool in diagnosing and preventing colorectal cancer, but it is not perfect. And PCCRCs are the preferred term for cancers diagnosed more than 6 months, but less than or equal to 10 years after a CRC negative colonoscopy. And some of you might have heard of the term index colonoscopy, which is also synonymous with a CRC negative colonoscopy. Essentially, it's the colonoscopy that they had initially, and eventually they were diagnosed with colon cancer. And many factors can contribute to a PCCRC. They include failure to intubate the cecum or inadequate bowel preparation, meaning the colonoscopy wasn't quite complete. Also suboptimal inspection techniques leading to missed lesions, or incomplete removal of lesions that eventually became malignant. So for the last two, pretty much lesions that weren't resected. And the World Endoscopy Organization, or the WEO, they actually came out with a consensus statement looking into different factors that can lead to PCCRCs, and they compiled a list of different things and list of different categories, and they made recommendations for how to look for potential causal factors and how to perform a root cause analysis to determine the most plausible explanation for each PCCRC. And our objective was to use the WEO approach to develop a PCCRC registry, incorporating the data elements proposed by the WEO, and perform a root cause analysis and classify PCCRCs into the categories that they propose, which includes possible missed lesions. And within that, that includes those with prior complete colonoscopies with adequate bowel preparation, and those with prior colonoscopies that were negative, but they were incomplete colonoscopies and or also had inadequate bowel preparation. This also includes detected lesions that were not resected, and those who had likely incompletely resected lesions. And ultimately, the last category is something that we can't quite prevent, is if the PCCRC was likely a new colorectal cancer. And this was actually the first study to date within the United States. There are some smaller scale studies within the United Kingdom, but they had like smaller sample sizes, and it's only like within like a small center. So we identified about 1,497 Kaiser Permanente patients who were over 18 years, who had a CRC negative colonoscopy between the years of 2006 and 2017, and were later diagnosed with CRC 6 months to less than 10 years after the procedure, so consistent with PCCRCs. And then we randomly sampled a 35% subset of those cases, a size of about 533, and abstracted patient and provider characteristics and findings of the CRC negative colonoscopy, and the follow-up plan from the CRC negative colonoscopy. And we performed a root cause analysis proposed by the WEO, as you can see on this slide. And then I'll kind of walk through an example of how we utilize this root cause analysis. So first, we looked at if the index colonoscopy or the previous colonoscopy was more than 4 years ago. If it was more than 4 years, then the likely category and etiology for the PCCRC is a new colorectal cancer. But if the answer was no, and the index colonoscopy was less than 4 years, we looked at if the index colonoscopy had an advanced adenoma in the same segment. And advanced adenoma meaning more than 10 millimeters in size or containing villus components. And if the answer was yes, and they had an advanced adenoma in the same segment as a later diagnosed colorectal cancer, was the lesion resected? Yes or no? If the answer was no, falling down the slide, so around here, if the answer was no, then the etiology of their PCCRC was likely a detected lesion that was not fully resected. And then there are different algorithms within this, as you can see, but I won't walk through each one of those. So getting into our results, so within our 533 patients, 197 of them, or about 37%, likely had a new colorectal cancer as the cause of their PCCRC, or etiology, so to speak. And then those who had a PCCRC that kind of revealed itself less than 4 years, that was about 336. And we kind of looked at those within the 336 individually within each subcategory, because these are actually factors that we can control. We can't control whether someone gets a new colorectal cancer, unfortunately, unless like genetics and stuff gets better in the way distant future, or like, things I won't approach. But so within the 336, as you can see within our results on the bottom, the largest percentage was 70.2% over here, as the highest likely etiology being missed lesions, and they had an adequate exam. So meaning they had a complete colonoscopy, the cecum was intubated, the preparation was adequate, and then the advanced adenoma was not, or a advanced adenoma was not seen in the same segment as a later diagnosed colorectal cancer. Other things to highlight as well, missed lesions with inadequate exams are about 15.5%. Incomplete resections from detected lesions were about 11%, and detected lesions that were not resected were 3.3%. And then this is again going into those who had PCCRCs within 4 years of the CRC negative colonoscopies, and kind of delineates and gives like a more pictorial demonstration of how significant missed lesions are in terms of the etiology of PCCRCs, 70.2%. And then highlighting some of our results as well. These are the demographics of our patients. I won't go into it in detail, but as you can see, similar to most other studies, a large proportion of our patients are non-Hispanic whites at about 70%. But we do have some diversity, about 10% in Asians, 8% in Blacks, 10% in Hispanic whites, and 0.4% in like others or those who didn't report. Something else I want to highlight as well, a majority were current or former smokers at about 56.6% here. And then this slide highlights endoscopist characteristics at the CRC negative colonoscopy. And then one thing that I do want to mention is that there's a known inverse relationship between ADR or adenoma detection rate and the proportion or likelihood of having a PCCRC. And that's why there is like an ongoing known importance and emphasis on ADR as a colonoscopy quality metric. So as you can see, those who had an ADR that was 32 to 61%, they had a median, or their PCCRCs were a percentage of about 70.4% of their total, versus those who had the lowest ADR, less than 19%, they had the highest percentage of PCCRCs. So in summary, approximately about 40% of PCCRCs were classified as likely new colorectal cancer. For those we can control, those within less than 4 years, missed lesions with adequate exams were the likely explanation for a majority of PCCRC cases. And incomplete resection are explained by about 11% of the PCCRC cases within the 4 years of a CRC negative colonoscopy. And so our suggestion for potential areas of focus in the future are to try to optimize and improve upon ADR as a quality metric, and also incomplete resection as a quality metric as well. So in conclusion, our findings underscore the importance of ongoing efforts to optimize colonoscopy quality, particularly the detection and removal of precancerous lesions. And again, I want to acknowledge all my co-authors, Jeff Lee, Sophie Merchant, Chris Jensen, Austin Lamb, and Doug Corley, and Prosper for funding this study. Cool. Questions?
Man, Lawrence, that was amazing. Kudos to you not only getting publication to any journal but gastro in your first year is a huge feat, and just to hold all those different types of sort of missed lesion, identity exam detection, that seems that was really good. I'll pause really question. I do have some questions, but I'll let the audience ask if anyone has any.
Did you look at, or are you guys going to look at non-advanced adenomas in that cascade, because the majority of the things that we find are tubular adenomas, which are not considered advanced.
Yeah,
And if you guys are going to look at that, are you guys going to look at like size of them, or your like number and things like that? Just curious.
Whether looking into non-advanced adenomas and whether we will, that's not something that we focus on, because we based this entire study modeled after the WEO, the World Endoscopic Organization consensus statement. And then they felt like advanced adenomas, so, you know, more than 10 millimeters in size or having high risk features, are the most high risk for developing into colorectal cancer in the future. And so that's why they kind of modeled looking at whether they had an advanced adenoma in the same segment as their later diagnosed CRC, to kind of delineate whether it was like a missed lesion or it might have not been a missed lesion. Just because in theory, if they had like something smaller, it would take, you know, a lot longer for that to present as colorectal cancer in the future.
And then Paul had a question that I'll piggyback on after, but were you able to identify the locations of the missed lesions in terms of left versus right? I'm not sure you mentioned that in one of your tables. But...
Yeah. We do have the details for that. I don't remember off the top of my head, but that wasn't the focus of what we published. But we do have those numbers. But...
And I piggyback on like sort of locational lesions, but like also the type 2, like were those ones that were sort of that missed lesion, adequate exam, or detected that was not resected? Were they in the advanced adenoma diagram that you mentioned? Were they SSA, TVA, like tuberous adenomas, or I guess female adenomas type?
Yeah. They were mainly just looking at like adenomas. SSAs were kind of a little bit different, so that wasn't quite the focus of this. They're more subtle. They're easier to miss. So.
Yeah, and I guess like just curiosity ones where, you know, you include that 1,497 patients who had the PCCRC, but what was that pool of just in terms of just overall prevalence of the PCCR at Kaiser?
Yeah, so the 1497 were pretty much everyone we identified with PCCRCs from Kaiser within that period, based off of like using like an analyst to pool that data. And we looked at a subset more so just because going through 1,500 charts was a big hurdle for.
No, for sure. Because like, do you know like, that comparative to the 14 among how many?
Oh,
just in terms of the percentage of the PCCRC, like overall prevalence.
Yeah. I don't remember off the top of my head, but I know it was like less than like 5% or something like that.
And lastly, how'd you come with the 4 years thing? So like 5 versus 3.
Yeah. So the 4 years is very arbitrary and something we've talked about this before. So it was a WEO recommendation, and then, you know, the WEO is just, you know, like a bunch of really smart people in the field of GI who kind of just met and they're like, hey, we like 4 years, let's go with 4 years. And the thinking behind that was that if you had a colon cancer at the index colonoscopy that was not diagnosed, ideally you will be symptomatic and diagnosed with it before 4 years of time. You know, it's pretty arbitrary. They picked a random number, but that's what they felt like. You know, if a colon cancer was missed, then you'll have symptoms and be diagnosed within 4 years.
Awesome. Yeah, the take-home message with the ADR as a quality metric is always something that I think Kaiser is one of the leaders in the field of doing. But just looking at the data, what is something like delta of 10%, which is your quartiles of ADRs compared to a low one, it was also about 17% lower. And maybe doing some analysis, and you probably did it right, we're looking at greater than 50% ADRs.
Yeah.
It's probably even lower than that, 17% versus 27% from the highest to lowest. It's not as reassuring. Yeah, so thanks so much, Lauren. I really appreciate it. We'll go ahead and move on to the next speaker. This is going to be Frances Lee. This is I've known Frances Lee for a while, so I'm pleasure probably introducing her. But she received her medical degree at Leung University, followed by internal medicine at Emory University. She's currently actually second-year GI fellow at CPMC, and is actually starting her transplant hepatology year in July as part of combined gen hepatology track. We've been my co-transplant fellow in the same Bay Area. And there's spare time to actually explore California as well as her dog, with her dog and her fiance. So go ahead, Francis.
Hi, sorry about that. I have two projects to go over. One is more of a liver study, and another is actually very relevant to what we were just talking about, looking at the impact of artificial intelligence in the form of GI Genius on ADRs for our attendings, and hopefully we can apply this to fellows in the future. But this was our quality improvement study that could also be kind of like switched to a retrospective as well. So the first study, we looked at CytOPeme-induced neurotoxicity in patients with liver disease. And so in our internal medicine training, I'm sure you guys have all seen CIN or CytOPeme-induced neurotoxicity for patients with renal dysfunction. But then, over time, there have been kind of this accumulation of case reports about CIN in patients with cirrhosis. And so usually when someone has CIN, they have some sort of like altered consciousness or change in their neurologic status within 48 hours or after, actually, sorry, that's a mistake, after 48 hours of CytOPeme initiation, and then it can stop after the CytOPeme is discontinued. And usually these are kind of like non-focal presentations of encephalopathy, but oftentimes you can also see myoclonus and even some agitation. And generally this is very separate from hepatic encephalopathy. And we don't really understand kind of like the pathophysiology for this in patients with liver disease. For patients with kidney disease, we know that CytOPeme is renally excreted. And so it seems very intuitive that you would have kind of like a high therapeutic state for those patients. But for patients with liver disease who don't necessarily have renal disease, certain pathophysiologic mechanisms can include, increased permeability of the blood-brain barrier due to increasing like hyperammonemia or other toxins in the blood, and just changes in the permeability as well from just in systemic inflammation. This is not very well known, but we are seeing it increasingly in clinical reports. And so we designed a retrospective case control study in which we looked at all patients who were admitted to CPMC with cirrhosis and had at least 3 days of CytOPeme exposure. Then we took all those patients, this was between the years of 2018 and 2022. We took all those patients and we chart reviewed them, and then we started stratifying them based on these 4 categories from CIN unlikely, CIN possible, probable to likely. And so unlikely and likely are kind of the polar opposites. Unlikely, this patient did not have even any sort of confusion noted in the chart. CIN likely is that there was confusion noted in the chart, and that that was, documented to be possibly or likely CIN from either neurologist or hepatologist. In the middle is CIN possible and probable. And this has to do with the presence of confusion with or without some confounding possibilities, and kind of like timing of the resolution of like that change in neurologic status. So if this changed, if the change resolved with cessation of CytOPeme, then we stated that as to be probable. So taking a step back, after we designed the case control study, then we had a data collection with a data steward who collected these charts based on ICD-10 codes between the years of 2018 to 2022. Then we started chart reviewing, and as we all know, this was kind of a handful. We had one fellow, which was me, one resident, and then someone to kind of split the difference. So the fellow and I, or sorry, the resident and I, we separated each of the charts into those 4 groups. And then if there was something that if we need to like break the tie, then the transplant hepatologist kind of broke the tie. Ideally, we would have liked to have a neurologist on board, but we weren't able to have one on our team. And then from there, we ended up doing an analysis, and we grouped these 4 categories into kind of like a 0 and 1. So CIN unlikely and possible were in one group. CIN probable and likely were in another group. We used a data analysis an expert with us, and she used her data and did some logistic regressions. So if we kind of take a step back and we look at those patients that had like the confirmed CIN, we wrote up a really quick case series on them as well. And so their ages range between 42 to 73. Most of them were pre-transplant, but there was one person who did have what seemed to be CIN after transplant, almost immediately after transplant. Most patients had some sort of like hypersomnolence, but a fair number of them, 3 of them had myoclonus as well. One patient had total aphasia that actually resolved once the CIN got stopped. And then the patient who had this documentation of CIN after transplant actually had a very strange agitation, which was just very, atypical of any other kind of neurotoxic kind of stimulus, either from whether it's CIN or whether it's like from Prograf or something else. So it was very interesting. Interestingly, the MELD scores kind of range very widely. And then as you can see, dialysis use was in the majority of our patients. There were only 2 patients who did not have dialysis. So one of the patients who didn't have dialysis did have a renal dysfunction. But then when we look at kind of the bigger population, so of all the patients that we looked through and collected, about 104 were included in our study. And then when we broke everything down and then separated into the 2 columns with CIN likely to possible and then CIN possible to probable, we did our analysis, and this is just a demographic slide. We didn't see much of a significance in kind of the 2 results based on whether it's age at admission, sex, race, or the etiology of liver disease. And then when we looked at kind of more details of the patients themselves and like their medical their kind of the severity of their medical illness, we found that basically if patients had sevapeme exposure like around their transplant date, then that increased the likelihood. Most patients had the sevapeme stop after transplant. So usually what happens is these are the patients in the ICU who get started on sevapeme as a broad spectrum antibiotic, and then they get transplanted, and then they complete their course of antibiotics, and then it stops. So it generally has a stop date. As you would imagine, the likelihood of CIN was associated with a higher MELD score and a MELD NA score, and as you would imagine with a creatinine, interestingly associated with a higher bilirubin, associated with a lower albumin, and as well associated with dialysis. And just to kind of note, taking a step back, which I should have said, when you combine the 2 groups, the CIN possible to probable, the N is 13 in our total of 100. So really the incidence is quite high, greater than 10%. So we thought that this is an interesting study, something that can kind of inform your antibiotic use, something that people can be aware of in terms of maybe waxing and waning mental statuses of patients. Just another kind of wrench in the whole schema of patients with decompensated liver disease. We can stop here for questions, or I can kind of quickly move forward to the next project.
I guess with the interest of time, let's have one quick question. I think this is amazing feat, Francis. I think just to kind of tease out, given often mental status itself is so hard to code and have so much differential potential causes. But I guess for these patients, it seems like most of your problem, like they're very, very sick, higher MELDs, hospitalizations, higher bilirubin, higher NR, so a lot of liver dysfunction. But were you able to, how did you tease among those patients compared to hepatic encephalopathy secondary to hepatic failure?
Yeah, that was really tough. So what was really nice was that most patients were very obviously confused or very obviously not confused. And then when there were those confounders, then we would just kind of put them in the middle and then also look at the sequence of their encephalopathy, look at their antibiotic use, and then place them either in probable or possible. What was nice is that it was actually pretty obvious, like if it was more driven by the hyponatremia or by sepsis, it was very, very clear from the chart. And our data stewards are great. And so they're able to tell us when this antibiotic started and stopped, so we can kind of see based on those dates what the notes said. But it's also kind of dependent on the quality of the notes, and that changes over time too. So it was definitely a challenge at times.
Yeah, I'll say that's probably one of the major limitations you can discuss in your paper, and just kind of tease that out in the methodology, and then maybe using hepatic encephalopathy as a baseline as your controlling variable in one of your demographics, and that way you can control it for your multivariable analysis.
Yeah.
Cool. You want to just move on to the next one? For, I guess,
Yeah.
is your next one pretty short?
Yeah, it's pretty short.
Okay,
it's just a QI study, and very similar to what Lawrence was talking about. But in our hospital, we started GI Genius in January of this year. And so we wanted to see if ADR was influenced by that quality improvement measure. And so we do some of the screening colonoscopies at CPMC. Most of our attendings actually do them at an outpatient endoscopy center. And so the subset of patients who are doing their screening colonoscopies at the hospital are kind of the sicker populations, the patients with a higher BMI and things like that preclude them from going to the outpatient endoscopy center. So kind of keeping that in mind, we wanted to see like, how is this affecting the ADRs for our attendings, and hopefully we can apply this to fellows in the future. So again, our objective, starting from the left, was to improve ADR using GI Genius. And so we created a baseline ADR with the help of our data stewards. So we looked at all screening colonoscopies at Van Ness from January to December last year to, that should be 2022. And then we calculated the polyp detection rate and then the adenoma detection rate. We excluded patients who were not having a screening colonoscopy. So people who had prior polyps, people who had IDA, hematochezia, family history of CRC. And then we also excluded attendings who did not do more than 10 of their screening colonoscopies at this facility. Like I said, most of them do it at a separate facility. And then we looked at basically the same things with the same exclusion criteria starting this year. And so, with those inclusion and exclusion criteria, we actually only had 6 attendings who kind of met that criteria of having 10 colonoscopies, screening colonoscopies at Van Ness, and then also had screening colonoscopies in the year of 2023. And so you can see that the 6 attendings are labeled A through F. We have the number of colonoscopies that they did with a polyp, with adenomas, and then the total number of colonoscopies that they did that year in 2022. Oops. And so the polyp detection rate kind of ranged, the adenoma detection ranged as well, from 27% all the way up to 50%. Then we look at 2023 and we basically did the same numbers. You can see that the ends are very, very low in 2023 because this was really just the first quarter. And again, most attendings are doing their colonoscopies at a different center. We even have a 0% here, but that person only did 3 colonoscopies. And I think most of them were with fellows. So, take that with whatever kind of interpretation. But interestingly, a lot of these attendings who are doing substantial number of colonoscopies at CPMC did see an increase in ADR, including the people who are extremely high performing, people with an ADR 50% to begin with, all the way up to 60%. And so in graph form, I have this over here, A being 2022 polyp detection rate and adenoma detection rate, B being the 2023 polyp detection rate and adenoma detection rate, and C being the change in 4 of the 6 who basically had enough colonoscopies to demonstrate that there was some change. What was interesting is that only one attending had change, like more change in the polyp detection rate than adenoma detection rate, but most attendings did take out more adenomas in general. And so basically our conclusion is like, there might not be an upper limit for kind of our adenoma detection rate. As Lauren's kind of exhibited, the higher your ADR is, the lower your PCCRC is. And if we can improve even our most accomplished attendings, then I think there's so much to learn for fellows, and so much we can do to prevent long-term, colorectal cancer incidence and PCCRC. That's it.
Thanks, Francis, for this bonus study. I think that the idea is, unfortunately, I'm glad it's at CPMC. Most fellowships right now do not have it, so at least we have some data from you. But I think that basing your sort of attending that, I feel like we don't take the A, C, and D serious, versus the other ones are just too much for low end to make a comment. But I'll be most interested in seeing that attending D, because I feel like when you're attending to have high ADRs, the GI Genius, the cost doesn't really improve. Basically, the cost benefit ratio is not as high for the high ADR performers, but that 14%, I'm more interested in seeing if that we can improve. And so we have, I know we started at the end of the hour, but I would love if you guys can just see for 10 minutes. We have one more presenter. He's actually the youngest presenter in our webinar series, I think, for as long as I remember. His name is Dr. Shyam Patel. He is actually a recent graduate of UCSF. So he's in that sort of window from medical student to starting the residency very soon at CPMC, where he'll work with Francis. And then his goal is really eventually pursue a career in GI hepatology. His current interests, for folks who don't know him, really lies in the intersection of social determinants of health, fatty liver, and in spare time, it's like just to run film photography as well as cheering for the Fresno State Bulldogs. But yeah, so I'm so sorry we're running a little late, but we'd love to hear you talk about the stuff.
Yeah, thanks for having me, everyone. I promise I will be efficient as well. Like Neem had said, I just graduated from UCSF and did a project with my mentor, who is a hepatologist, Dr. Khalili, at the ZSFG. And so got to work with a vulnerable population. The title of my talk is Formal Fatty Liver Education Enhances Uptake of Physical Activity in Vulnerable Groups, including those with unhealthy alcohol use. And so a little bit of a background. As we know, FLD is just like the name suggests, it's an excess deposition of fat in the liver. And we get really concerned when it starts to cause hepatitis or inflammation in the liver, cirrhosis, and can even independently cause hepatocellular carcinoma. We've had a growing prevalence in the United States, especially as we have a parallel growth in diabetes, obesity, and metabolic syndrome. And so just to define FLD a little bit for our project, fatty liver disease can have a number of different causes. The two most common that are in our cohort are alcohol-associated liver disease and metabolic-associated fatty liver disease. Clinically, you might see in your practice for all these fellows out there that they coexist in patients. Recent studies have suggested that they may share some mechanistic pathways. Some examples would be like insulin resistance, lipid dysregulation, oxidative stress, and fibrosis among the two causes of FLD. And although a lot of those studies have just been done in basic science applications, a lot of epidemiological studies have also suggested that disease progression likely converges and possibly is even synergistic between these two causes of FLD. So while a majority of patients report heavy drinking develop fat in the liver, only 35% will actually progress to advanced ALD, further suggesting that there might be something beyond alcohol that could be causing disease progression in this population. And it can't be, it has to be said that also FLD, like other chronic conditions, I know this specifically talks to NAFLD, also includes health disparities. So in the United States, Hispanic populations are the most affected disproportionately with NAFLD. Right now, the only treatment that's available is lifestyle modification, like diet change, physical exercise, alcohol reduction, cessation. Studies have shown that physical exercise, even irrespective of weight loss, has been associated with metabolic health and reduced FLD. You know, as providers, we're always trying to see how can we get our patients to adopt some of these new lifestyle habits, and health education programs have been really effective in other chronic conditions like diabetes and high blood pressure. And so this brings us to our objective. And so we wanted to identify factors associated with physical activity at baseline and the impact of implementing formal fatty liver disease education on improvement in physical activity in a racially diverse and vulnerable population at the San Francisco General Hospital. A little bit about our methods. We're receiving care at the FLD clinics in the San Francisco Safety Net healthcare system from 2020 to 2022. Inclusion criteria included a diagnosis of FLD and willingness to consent, and exclusion criteria was, you know, the opposite and included severe medical or psychiatric conditions. And the intervention was really, really interesting. It was a formal 60-minute FLD education session conducted by one of the hepatology nurse practitioners at the General. It was offered both in person and remotely, usually in a group of 10 people, using PowerPoint slides. And the patients got to learn a plethora of things. They got to learn about diagnosis, management options, lifestyle modifications, including, you know, some of the things that we had previously described. And this was all translated with the aid of certified medical interpreters for non-English speakers. Most people in this population spoke Spanish, and so we got the interpreters needed to teach them as well. A little bit about the data collection. So we looked at physical activity levels both before and after the educational program at 6-month follow-up. And the way that we created a physical activity score for these patients was looking at duration of physical activity as recommended by the AHA guidelines. So patients were subcategorized in, you know, having no physical activity, insufficient physical activity from 0 to 150 minutes, or the recommended of at least 150 minutes. And then intensity was described by kind of like the MET score, if it was light, moderate, or vigorous activity. And then that's how we came to create a combined physical activity score, with optimal exercise being moderate or vigorous activity of any duration, suboptimal being light activity of any duration, and no activity being none. And when we were choosing our predictors for this, we really looked at the National Institute on Minority Health and Health Disparities Research Framework, which really places a lot of value on you know, looking at health outcomes with the socio-ecological models. And so there's a lot of intersecting factors between the individual relationship and community and societal level that affects patient outcomes. And so some of the predictors that we had set before we did our analysis were looking at clinical, psychosocial, and social determinants of health. So getting to our results, you know, our baseline characteristics, there was 314 patients enrolled, like I said earlier. 262 actually underwent education and completed the pre and post-education surveys. And compared to those who reported any exercise, those who were not reporting any exercise were more likely to be younger, actually, with a median age of 49 versus 55. Female, 64% versus 56%. Identify as Hispanic, 66% versus 53%. Be unemployed, 57% versus 36%. Be in a larger household, which was described as having 3 or more individuals in the household, 61% versus 54%. Be obese, 75% versus 55%. And endorse heavy and binge drinking habits, 30% versus 22%. And so this was our multinomial logistic regression for physical activity at baseline. We compared patients in that suboptimal group and optimal group versus those with no physical activity. And what was really interesting that we found was that older age was significantly associated with physical activity at baseline, which you may think is the opposite of what you'd expect. But I was looking at some literature, and I think especially in our population, this population really relies on employment and income to support themselves and support their family. And so most likely older populations have more time for leisure activities like physical activity at baseline. After education, we found that 91% versus 74% at baseline reported engagement in physical activities at 6 months. 58% were exercising at light intensity, 32% moderate, 10% vigorous, 61% were reaching the recommended exercise duration. And so when we had done our analysis after FLD education at 6-month follow-up, we found that older age was associated with less probability of improvement in physical activity. Hispanic versus non-Hispanic race was associated with a higher probability. And on multivariable analysis, when we controlled for things like age, race, age, sex, and any other univariable analysis that was p less than 0.05, we found that Hispanic participants had a significantly higher probability of reporting improvement in physical activity compared to their non-Hispanic counterparts. And we also did a sensitivity analysis where we looked at 170 participants who initially reported suboptimal or no exercise at baseline. And what we found on both univariable and multivariable analysis was really interesting in that compared to participants that did not drink alcohol, participants who reported heavy binge drinking had a significantly higher relative risk of reporting optimal activity at follow-up. And so, thinking about the parallel nature of FLD in terms of ALD and MAFLD, this was really timely to know. We found that formal FLD education can result in an increased adoption of physical activity, especially among a safety net population. Hispanic participants were especially receptive to educational intervention. And this was really novel that, those with unhealthy alcohol use improved in physical activity after FLD education, which shows that, maybe, they are open to optimizing their metabolic health to mitigate further liver damage while pursuing treatment for alcohol use down the road. Further investigations in our group are looking at this FLD education's impact on clinical endpoints. And thank you for listening.
Thanks, Shyam. I absolutely love this initiative and really have worked with them at SFGH personally and know the amazing education that they're getting with our amazing NPs. I think that we have the most data and I feel like this is amazing. The one thing is just whenever we talk about these studies, it's basically feasibility. And how can we kind of like a model that other centers can be used, given that it's just rather than very center specific. So hopefully you guys are sort of establishing that and hopefully making a framework that other, other community clinics as well as CCNet Hospital can also model off there. And then, the last comment is really, you hit the nail on the head where alcohol use, and I feel like that's education, just motivating and taking hepatology, taking ownership of just managing fatty liver and alcohol use disorder, rather than just referring us to our next really needed step. So kudos to you and your efforts. Really appreciate it.
Thank you. Yeah, thanks everyone for tuning in. I know we're like 15 minutes over, but I appreciate it.
But yeah, any other questions for folks that are still on? I really appreciate it.
Good job.
Thank you.
Thanks, Scott. All right, well, that concludes our seminar webinar. Really, thank you, everyone, honestly, for staying towards the very end. And this is our last webinar for our academic series. And hopefully we'll release the next one soon for the 2023-24 year. Thanks, everyone. Have a good night.
Good night.